Uh, Thank you very much for inviting me and Dr. Karthikeyan as well. Thank you. I'm going to give a broad overview because I know Abhishek is going to talk about devices and Shifal is going to talk about ablation. Um, my slide is, there we go. So let me, before I go to atrial fibrillation, let me show you a different case, a different scenario. Here is a long RP supraventricular tachycardia. This is an 18-year-old girl with a 17% ejection fraction and was placed on a transplant waiting list. It turns out to be eventually we studied her a permanent form of junctional reciprocating tachycardia, and mostly accessory pathway tachycardias have a short RP tachycardia, but this is a long conduction time, typically around 500 milliseconds or 120 beats, and fairly incessant. Even if it breaks after a couple of beats, it comes back because of the large excitable gap. And these patients get into a kind of getting onto a treadmill and never getting out. They seem to become pretty sick. And once we ablated her successfully, and this was the location of the ablation, and her ejection fraction completely normalized in about 3 months. So there are other arrhythmias that we need to really focus on. I mean, not only on atrial fibrillation. This is a post-ablation EKG. We also shouldn't forget atrial flutter, which is the classic sawtooth appearance in counterclockwise with positive flutter waves in V1. And this is fairly, in 40 to 45 minutes in the EP lab, one can nearly offer 98% chance of lifelong cure. And really performing a cardioversion takes about 5-10 minutes to put the pads, and this takes about 45 minutes to produce lifelong cure. So I really think ablation should be the first line of choice or therapy for typical atrial flutter, which is not uncommon post coronary artery bypass surgery or valvular surgery. And this is the typical location of the ablation. Here is the tricuspid valve, coronary sinus, mitral valve. And from the IVC, if you deflect the catheter and create a linear line across these, sometimes it is difficult to go across these pouches and valleys, but for the most of the time, it is fairly easily achieved for nearly lifelong cure from this arrhythmia. But the most important topic for today is atrial fibrillation. As you can see, it causes significant increase in death rates, strokes, hospitalization, reduction in LV function, and quality of life. Now, the most important thing is, why is atrial fibrillation so common among patients with atrial fibrillation? So if we take congestive heart failure, it leads to left atrial stretch due to hemodynamic overload, which leads to atrial dilatation, and atrial dilatation perpetuates atrial fibrillation by causing a lot of areas of scarring. And also the same altered calcium handling from CHF causes electrical abnormalities. All of them ultimately lead to atrial fibrosis. And once you have myocyte death, myocyte uncoupling, or mechanical stretch, you have significant degree of atrial fibrosis, which perpetuates atrial fibrillation. And this is elegantly shown in we also have started using recently these 3D, 3 Tesla late gadolinium enhancement MRI scans, where you can see the percent fibrosis in the left atrium. Here is a less than 5% pulmonary atrial fibrosis, and here you can see 35% fibrosis. So really, this patient is unlikely to maintain sinus rhythm on ablation, and all these three may be, and this is definitely more likely. And here, clinical judgment is required, and if it is essential, one can pursue this option. Now, if you look at patients with congestive heart failure, over 10 years, if you follow them, about 35% develop heart failure. And develop atrial fibrillation. And if you follow patients with atrial fibrillation, 35% of them over 10 years will develop congestive heart failure. So these are kind of mutually related conditions where there's a significant burden of nearly 40% of patients will have some form of atrial fibrillation through their life of congestive heart failure. It's very rare for someone to maintain sinus rhythm in advanced stages of heart failure. And you can also see the influence of rate. If you can keep the ventricular rate around 70, the ejection fraction stays around 60%. This is the mean heart rate. If the mean heart rate is in the 120s, the left ventricular function quite significantly declines. So there will be competing theories of pure heart rate induced reduction left ventricular function due to ATP depletion versus the RR fluctuation, which is also causing significant constantly fluctuating hemodynamic loads. But the one thing that I always look for is to look for the longest RR interval and look at the ejection fraction and look at the shortest RR interval. There is a significant difference. Restoration of sinus rhythm is a worthwhile venture because the likelihood of reversal of left ventricular function is very good. The choices of antiarrhythmic drugs are very limited. The main two drugs are amiodarone and dofetilide. We really cannot use dronedarone because it's pretty significant. The mortality increase has been shown, and it's an absolute contraindication, and none of the other drugs can be used. So essentially, we're fluctuating between dofetilide and amiodarone. If the kidney functions are good, we can use dofetilide. If the liver functions are bad, again, dofetilide. But if the kidney functions are bad, amiodarone. For the most part, amiodarone is the most frequently or widely used drug. About 40 to 50% of patients will maintain sinus rhythm, but there is a significant drop-off. You can see that the patients on amiodarone, about 25% will discontinue the medication because of some kind of side effects, whereas with dofetilide is at about 10 to 12%, probably due to fluctuating renal function or QT prolongation. So it is not that drugs are not very good or are inadequate for management of atrial fibrillation in congestive heart failure. So this Bordeaux group was the first one to say that ablation was very useful in terms of not only restoring sinus rhythm, but maintaining it and actually improving or reversing left ventricular function. So restoration and maintenance of sinus rhythm by catheter ablation without use of medications produce significant improvement in left ventricular function, quality of life symptoms, and exercise capacity. But the most often quoted study today is the Castle AF trial, which was published in 2018. 179 patients were randomized to ablation arm and 184 to the medication arm. Interestingly, all patients had defibrillators, so it's a perfect way of monitoring the burden of atrial fibrillation. And patients were in class 2 to ambulatory class 4 heart failure, EF less than 35%. And the conclusions of the study was catheter ablation significantly improved the outcomes. So here are the outcomes. Let me point out, this was one of the most significant study. Death from any cause showed 24 in the ablation arm and 46 in the medical therapy or conventional medical therapy arm. This is a kind of a dramatic reduction. This is over a period of 5 years. And you can look at the CV death was half and heart failure hospitalization was nearly half. So this is quite a dramatic benefit. You can see the curves start separating in about 12 months, and the benefit continues to widen as time goes on. And therefore, this is quite a remarkable achievement. Now, the larger Cabana trial with a subset of heart failure patients showed nearly the same results, although the magnitude of benefit was slightly smaller compared to the Castle AF trial. I know Abhishek is going to talk a lot about this, but this is a 71-year-old female with non-ischemic cardiomyopathy with the left bundle branch block, Chikiura's duration of 150 milliseconds, EF had already dropped to 28%, and diastolic diameters approaching 70 millimeters. We all know that in terms of CRT, that patients in sinus rhythm respond better than patients in atrial fibrillation. It is currently recognized as one of the indications or major indications of class 2A indication for patients with left bundle branch block with QRS duration greater than 120. If it's greater than 150, it becomes a class 1 indication. Now you can see that this particular patient, due to various other comorbidities, ended up undergoing a biventricular device. This is a slightly older patient. With nowadays we use quadripolar. We don't use a bipolar lead in the left ventricle. And once we, so what do you do after CRT? Should you ablate atrioventricular node or not ablate atrioventricular node? There are cumulative evidence suggests that ablating the AV node in general benefits, produces significant benefit. The reason being 100% BiV pacing barring PVCs is probably the best outcome rather than pacing the patient 80% of the time or 90% of the time. Even 92% is inferior compared to 100%. In this particular patient, we had 98% BiV pacing. QRS, as you can see, became completely nearly narrow, and the EF started improving and a functional class improved. So in general, AV junction ablation is preferred in these patients if you cannot control, if you cannot maintain 100% of BiV pacing. Whether AV junction ablation should be done soon after the placement, or should you wait to uptitrate the beta blocker and other medications, including the digoxin, or should you do it immediately, has been a matter of debate, but vast majority of people give a little bit of time before medications have to promote the percent of biventricular pacing. So atrial fibrillation in congestive heart failure is a fairly common problem. It is going to occur because increasingly because of diabetes, hypertension, obesity, and all this lead to atrial fibrillation. It's not specifically just myocardial infarction, but accumulative problems of everything, that valvular heart disease and so on is increasing the burden of atrial fibrillation. And therefore, either amiodarone ablation or CRT with AV nodal ablation is going to be the primary therapeutic choices that we have at this time. Thank you very much, and I'm happy to answer some questions.